So I will turn it over to both of them for our didactic portion of today's lesson.
Thank you, everyone, for the opportunity to share this case. I will let Aracely start with it, and I will continue on with the case itself.
All right. Well, thank you so much to Dr. Lee and for everyone joining today. So I want to start by orienting everyone to our presentation for today. We're going to begin with a very brief one-liner of our patient case to set the stage, and then we'll follow with the didactic content that's going to cover post-COVID-19 syndrome, as well as PGX and psychotropic medications, following with challenges when integrating PGX with post-COVID syndrome, and then we'll dive more deeply into our patient case. Next slide. So today, very briefly, who we have is a 37-year-old female who's referred by her psychiatrist for PGX testing. She was complaining of worsening anxiety and insomnia, postpartum, and post-COVID-19 infection. So the main question we're aiming to answer today is how we should manage her anxiety based on her medical history and PGX results. Next slide. So you all may have seen or heard terms that describe this condition that occurs following a COVID infection, often going by terms as post-COVID syndrome, long COVID, and so on. Table 1 here, that's taken from the Takao paper, actually lists some of the different nomenclature, but they all essentially describe the same constellation of symptoms that we see related to patients that experience a syndrome that occurs long after their COVID infection has resolved. And the symptoms can range widely from fatigue to taste and smell disturbances, even down to neuropathy, anxiety, and depression, all of which have a variable rate of occurrence, which you can see listed here. Next slide. So going further with the post-COVID syndrome, it can really be split into 2 phases, where the differentiation between acute and chronic really happens at that 1-month mark. And the interesting thing about the symptoms from the previous slide, as well as these neuropsychiatric symptoms listed here, is that they can persist long after a patient has recovered from their acute COVID infection. And the symptoms can actually fluctuate and relapse over the period of their post-COVID syndrome. Next slide. And although I highlighted more of the neuropsychiatric symptoms on the previous slide, this figure here is really just to highlight that post-COVID sequelae can impact many different systems within the body outside of just the neuropsychiatric realm, which is important to consider. Next slide. So the truth is, the pathophysiology of a lot of post-COVID-19 sequelae are not really well understood. There are a lot of hypotheses that have been made that could potentially explain the cause of these conditions. So, for example, starting with the cognitive dysfunction, or as some patients have referred to it as a brain fog. So there's been a proposed pathophysiology related to viral infiltration into the brain, which can lead to myelin damage and inflammation. And that can be further compounded by the impact that COVID-19 itself has on the HPA axis and cortisol levels. So all of those may be implicated with the cognitive dysfunction. Going into the numbness that some patients have experienced in their extremities, it's potentially explained by small fiber neuropathy. And then lastly, the mechanism behind postural orthostatic tachycardia syndrome, otherwise known as POTS, is actually not very well understood, but it has been seen, and a lot of the symptoms listed here have been noted. Next slide. So related specifically to post-COVID syndrome and its impact on mental health, I highlight these 2 papers that could help describe the pathophysiology that may be underlying either a new onset or exacerbations of mental health conditions. So the first paper by Palanti and colleagues really demonstrated that there was this correlation between impaired neurological functioning and elevated levels of inflammatory markers. So denoting that there's some impact of inflammation on neurological functioning. The second paper by Wang and colleagues found that serotonin levels were altered in both acute COVID-19 infection patients as well as in post-COVID syndrome patients. And it was likely driven by mechanisms that were impacted by the viral inflammation aspect of it, in which these mechanisms that were impacted were things like decreased tryptophan absorption, thrombocytopenia, and increased MAO expression, all of which can lead to serotonin depletion and again, further impact the mental health condition. So what we've seen so far in these slides is that there's an implication of post-COVID syndrome in general, but also really specifically in the setting of mental health. Next slide. So here I really just like to mention the pharmacotherapeutic options that are available for anxiety and depression. And as I'm sure most of you are familiar with, SSRIs and SNRIs are typically our first-line options when it comes to treating these conditions. And the more downstream or alternative options are listed on the right-hand side of the column. So really, there's a lot of options available for patients. And I do just want to note, of course, related to anxiety specifically, not all of these have an FDA indication for anxiety, but there are many that are still frequently used off-label for that indication. Next slide. All right, and I won't really belabor the information on this slide too much, as I'm sure many here are familiar with the CPIC guidelines, but I did just want to highlight these specific guidelines related to serotonin reuptake inhibitors, antidepressants, that was recently updated in April of this year. And they denote very specific recommendations for the listed drugs in this table. And there are also separate CPIC guidelines related to tricyclic antidepressants. Next slide.
So I'll jump in here. A lot of us have heard of phenoconversion in the context of a drug interaction with CYP2D6, but in the case of inflammation, not many people might be aware that it has an impact on the phenotype. So basically, with phenoconversion, there is a mismatch between the predicted phenotype based on the genetic result and the patient's true drug metabolizing capacity. There are many causes for phenoconversion. We are familiar with, as pharmacists, the medication component with drug-drug interactions, but there are other conditions that come into play. And for this specific case, it was inflammation. There has been a growing amount of data to suggest that inflammation can alter the liver expression of these drug metabolizing enzymes, and even certain phase 2 enzymes like glucuronidation as well. So this results in phenoconversion. And this is where I want to pause and think, like, how does this impact our utility of those pharmacogenomic results? Because we do not know the degree of inflammation the patient is experiencing to translate those into the phenotype outcomes.